the previous promise of 30 minutes allocation. So now, without further delay, I'll just move to the third presentation, and I'd like to invite Achyut Raj Pandey sir to give his presentation on trajectory of probability of premature death PPD in Nepal.
Okay, thank you, Prantimaji. For next 15 minutes, I'll be talking about the trajectory of premature death in Nepal. And I believe it's a story of life, death, and money, or life, death, and resource. So let's first start with the concept we are very much familiar with. We have been dealing with the concept of life expectancy, often considered as a measure of survival. Life expectancy is the number of years a newborn would live if the prevailing patterns of age-specific mortality at the time of birth are applied throughout the lifespan. Whereas probability of premature death is the probability of dying before reaching the age of 70 years under current age-specific mortality rates. So when we deal about life expectancy, we need to bear in mind that it's influenced by age-specific mortality rate and the remaining years of life, whereas the probability of premature death is only influenced by age-specific death rates. So let me make it slightly more clear what I mean by this. The bar in the chart, the mortality and time somewhere between 1 to 6 days has a huge impact on life expectancy of people. That single bar can push the life expectancy of people slightly higher, but the probability of premature death is not influenced so much by this bar. And when we hear about the life expectancy of Nepalese people being 73.5 years, many people assume they would be living for 73.5 years. So the life expectancy, concept of life expectancy itself is quite relaxing. If I consider myself, I still have half of my lifespan to spend, and that's no rush. I can sleep additional 1 hour additional each day. And when it comes to concept of premature death, there's a twist. 1 in every 3 Nepalese men die before they reach the age of 70 years. And 1 in every 4 females die before they reach the 70 years. So there is no flexibility. It pushes people to reduce weight, maintain health parameters to normal level, and then live slightly longer. So these are the basic difference I see in the concept of life expectancy from the individual level. When we apply it to policymakers, there are some differences that make probability of premature death slightly more appealing, in my opinion, to the policymakers, because we are now heading towards aging population, with NCDs becoming slightly more prevalent in later stages of life. When there's more deaths in later stages of life and NCDs are more prevalent, life expectancy is not a good measure of survival or good measure of mortality. So we may go for premature mortality or the probability of premature death. It's because the probability of premature death is less influenced by the age at death. So in case of life expectancy, saving a 1-year-old child might be more appealing than saving 6 or 7 people dying at the later stages of life. But probability of premature death is not that influenced by the concept of the years of life saved. And it's easier to break down the contribution of each factors. We can precisely say what level of premature death is caused by NCDs, communicable disease, maternal and newborn conditions, and so on. So when it's easy to break down, it's easy to set targets as well, and it's easy to track the progress we have made against those targets. So let's directly jump into what the scenario in Nepal looks like. In 1990, the average life expectancy of Nepal was 58.1 years. And then we added 12.55 years by our management of communicable disease, maternal and neonatal conditions. We added additional 2.35 years from management of NCDs and additional 0.48 years from management of injuries or control of injuries. And in 2023, average Nepalese would be living 73.5 years. And if we go further to break down, major achievement in prolonging life expectancy have been achieved from the control or management of communicable disease, respiratory infections and tuberculosis, other infectious disease, enteric infections, maternal and neonatal conditions. These have the major contribution in prolonging the life expectancies of Nepalese citizens. And if we compile them together, 81% of changes in life expectancies we have since 1990s were attributable to communicable, maternal, neonatal, and nutritional conditions. So then let's be slightly future-looking. So if we compare our life expectancy with North Atlantic, that's Western Europe and Canada combined, then we are compromising 8.58 years of our life expectancy to the NCDs, and 3.78 years of our life expectancies to communicable disease, that is infectious disease, 8 infectious conditions to be very precise. So 7 NCDs and 8 infectious disease. These are the conditions. I won't go in details or read out the individual names. To be even more specific, if we break down further, we compromised more lives in the life expectancy compared to North Atlantic, to tuberculosis, and then atherosclerotic cardiovascular disease, tobacco-related non-communicable disease, and so on. So we can precisely break the contribution that has been made in achieving the life expectancy or let's say, prolonging the life expectancy. And if we consider the premature mortality, the concept is even more appealing, and I'll briefly deal about the trend we have. In 1990, almost half of people died before the age of 70. And in 2023, the probability of death is 30%. If you convert that into percentage, it's 30%. Somewhat similar among males and females. So in remaining slides, I'll be focusing on the premature mortality in 2023. So if we break down by gender, we expect around 34,700 people males die before reaching the age of 70 because of NCDs, 14,000 because of semen and disease, and 9,000 because of injuries. And among females, it's 27,500 deaths from NCDs before reaching the age of 70 years, 11,000 deaths from communicable, maternal, neonatal, and nutritional diseases, and 5,000 deaths from injuries. And these deaths can be attributable to specific risk factors. So 22,000 deaths among males occurring before the age of 70 are attributable to behavioral risk factors, 17,000 to metabolic risk factors, and 12,000 to environmental risk factors. And among females, 13,800 to behavioral risk factors, 11,400 to metabolic risk factors, and 8,000 to environmental risk factors. So going even more precise, cardiovascular disease is the main cause that lead people die before the age of 70 years in our context. 7% of people die before reaching the age of 70 because of cardiovascular disease. The proportion is 3.3 for neoplasm and 2.9 for chronic respiratory disease. And these 3 conditions together contribute 44% of premature deaths in Nepal. So it's very tough to reduce the premature mortality or premature death without addressing cardiovascular disease, neoplasm, and chronic respiratory diseases. And whenever we talk about NCDs, that's often a debate that from the equity perspective, it's equally essential to address the maternal and neonatal conditions. And we start discussing about why the resources should not be shifted to the NCDs. And if we dig out further, among the reproductive age group women in Nepal in year 2023, the leading causes of deaths are again NCDs. So we skipped 9 other conditions and directly jumped to the 10th, justifying reproductive health, maternal and neonatal conditions as the women's agenda. There are several other agendas that need to be addressed that are a problem among the reproductive age group women, which we somehow skipped and passed and have been debating. So I don't exactly get why we decided to skip the leading causes of mortality among females and then directly jump to the other conditions lagging behind in terms of mortality. And I won't read these rates and details. We have several factors that go beyond health sector: air pollution, occupational injuries, ambient particulate matter, lead exposure, that are well beyond health sectors, and we may have to have intersectoral coordinations if we want to address the premature mortality in the Nepalese context. So and then let's take a brief journey on whether we will be able to achieve the targets on premature mortality Nepal has set for future. So we have SDG target 3.4 to reduce the premature mortality from NCDs by 1/3. NCDs to very specific cardiovascular disease, cancer, diabetes, and chronic respiratory disease. So we, in 2023, we are in the same position, same level where we were in 2020. It's 20.4. And if this trend continues, we won't be achieving SDG target by 2030. To be slightly more diplomatic, we are very less likely to achieve this target by 2030. And if we consider the other target on premature mortality we have the 50 by 50 target for premature mortality. We need to reduce the premature mortality by 50% by the time we reach 2050, and by 30% by 2035. So if we want to achieve the premature mortality reduction by 50% with the current rate we have, we need total of 59 years. That means we will be achieving this target 30 years beyond the target we set, 30 years beyond the milestone we have set for achieving the premature mortality. And there are emerging challenges as well. So we have recently been recovering from the COVID-19 pandemic. And when we discuss about premature mortality, the sudden question that comes to mind is, what about the pandemic? So there's 20% chance that we will have a pandemic in next 10 years, which will be claiming 25 million deaths worldwide. So if we spread this death to 10 years, then 2.5 million deaths per year. And if we compare it to other disease conditions or diseases we have, then it's more than the deaths from HIV and AIDS, tuberculosis and malaria combined. And it's also more than the deaths from climate change and the most pessimistic scenario. So there's also need to be prepared for handling the next pandemic or have a health system orientation to deal with those challenges as well. And beyond that, there are some issues that seem really concerning. There are multiple factors that need to be addressed, but few factors that have been really concerning, but it seems like we have been ignoring for quite a long time. One of the factors is antimicrobial resistance. We have been losing 6,400 deaths that are directly attributable to antimicrobial resistance. Other 23,000 deaths are associated with antimicrobial resistance per year in Nepal. And if we want to have this in context, these deaths attributable to antimicrobial resistance is more than the deaths from lower respiratory infection, more than the deaths from suicide, tuberculosis, road traffic injuries, chronic kidney disease. We have been discussing about it for quite a long time. It's more than the deaths from diabetes, congenital defect, diarrheal disease, and maternal disorder. So we have been ignoring this aspect for quite a long time, and this has multiple other implications as well. We have been discussing that out-of-pocket expenditure is quite high, and that out-of-pocket expenditure bar is being pushed by medicines. And if we look at the consumption of medicines, we are the leading consumer of antimicrobials. We rank first amongst 57 countries in terms of per capita antimicrobial consumptions, despite having similar rates of infectious diseases. Something is seriously wrong, we can assume. And we are also consuming more antimicrobials from the WASH group. We are the fourth leading consumer of the WASH group antimicrobials. So there's clearly a need of regulation. And if we could manage to regulate this, maybe we can pull down the bar of out-of-pocket expenditure to some extent. And we had a lot of discussion on whether education will solve the issue or whether there's a role of price or tax that has to play in making choices of the health. And we have been asking people, we have been educating people to consume healthy diets. And if we consider the price rates, 21.4 million people cannot afford the healthy diets we have been prescribing. If you consider the World Bank data, it's 71% of the total population. And unhealthy diets, healthy diets are 2.2 times more expensive than unhealthier diets in our context. And if you compare with the global scenario, healthy diets are slightly more expensive than the global average in our context. So we have not been subsidizing the healthy foods. We have been educating people, and we have been telling people to consume the healthy diets that 71% of the people cannot afford. And we are also educating people to use the additional health services. We have been educating people to use the services when they need. And if they do so, we will have 22 lakhs inpatient admission between 2020 to 2030 in the period of 10 years. We'll have 11 crore outpatient visits. Each inpatient visit will incur 69,930 Nepalese rupees, and outpatient visit incurs around 1,755 Nepalese rupees. So we will have 22 lakhs inpatient and 11 crore outpatient visit in the period. And if we convert that into budget, it will consume additional 3.5% of the GDP, which doesn't seem feasible with the current resource being allocated for health. So we have been prescribing people to use service. We have been telling people to use service, but we have not been able to modify health system or strengthen health system to address all those challenges. So if we want to address the financing aspect of this problem, maybe like we would like to go for progressive premium rates for health insurance. We had a quite rigorous discussion yesterday. We can have targeted proper safety nets that can save additional resources. We can have harmonization of social security schemes. We discussed a lot about it today morning. Maybe improving efficiency and financial management could spare additional resources. And we may go for testing some innovative health financing options that could spare or make available additional resources for health. So this is the concluding slide. Nepal is likely to miss the target we have set on premature mortality. Every targets we have set on premature mortality, SDG 3.4, and 50 by 50 target, and 35% reduction by 2030. So we are very likely to miss all those targets. NCD contributes more in the gap of life expectancy we have compared to North Atlantic, Western Europe, and Canada combined. And more investment on NCDs can push the life expectancy bar slightly higher and also help us achieve the SDG 3.4 and 50 by 50 targets. That's all. Thank you.